A little bit of Strider.
Oh shit. This is for sure like a true emergency. Welcome back to our reactions to the Pitt. We are real doctors, a real couple, and I'm Dr. Peggy. I'm an emergency medicine physician. This is my husband, James.
I'm internal medicine. Hi.
Thank you so much for following along, being patient with our slow uploads. We're very busy. It's hard to get this guy to sit down with me and for me to finally sit down and edit these videos, but we are getting them out to you. We're gonna finish the entire season. And I don't know, there is a season 2 coming out too. I think it'll be out before we finish the season. But anyway, if you wanna find more of us, we are also on social media on my account. Here are my handles on TikTok and Instagram. And without further ado, let's get to episode 10 of season 1 of the Pitt.
28 years old, burned in a gas tank explosion. Paramedics estimate 90% BSA.
Trauma one's open.
90% body surface area was burned. Okay, so burn victim.
That doesn't look like 90%.
I mean, maybe his face is spared, I don't know. I mean, his face is burned, look.
Oh, that's true. Oof, that's pretty
Mainly
bad.
3rd degree.
Let's set up for intubation. Whitaker, run the Parkland formula.
Don't touch me. I'm fine.
Oh, she just got punched.
A patient hit you? Yeah. Happens all the time. Got my cheek broken.
I lost a tooth.
We've all been assaulted.
I don't know if it's that common.
No, I mean, that's pretty horrible that they're like, oh, we've all been assaulted. Like, we should
Yeah,
not
that's not
accept
a-
that. Like, that's not okay.
That's-
And it's definitely not that common. I mean, yes, we all have known of someone personally that has been assaulted before at work, but it's not every single one of us.
Yeah. Definitely everyone's been yelled at, but I don't know about.
Yeah, verbally
actually.
assaulted.
Yes, verbally
definitely
assaulted, yes.
for sure all the time.
Everyone.
But physically assaulted should not be that common, and I do think that in our culture in the ER, too complacent. Like we may be a little bit too like normalizing it. You're like, we all get assaulted, and I think that's a bad trend, and it shouldn't be that way. That may be a little bit of an exaggeration. I've never gotten punched.
Tell me when it's sore.
Oh, ow.
Oh, nasal fracture.
Hello, sir. I'm Dr. Garcia. You guys are these dressings.
We ready to intubate? Watch me here in a minute.
How is he? Stable for now.
Okay, honey.
Poor guy.
You've got severe
Look at
burns.
all that burns. He's got terrible scarring.
Yeah.
I need to put in a breathing tube and you won't be able to speak.
We need to do this now before his throat swells and it becomes difficult for him to breathe.
So it's like really important that they intubate the patient quickly. Yeah, like burns are like one of the things that are like they can be pretty severe if they are severe. And this guy's gonna have a very long road in the ICU. He's gonna be in the hospital for a very long time. It's basically the management of burns, it starts out mathematically. So depending on how much of the body percentage is burned, and we're counting full thickness or partial thickness type of burn. Not the red, like sunburn kind of burn, or even the slight blistering's not a big deal, but the more serious types of burns, we calculate that. We lose a lot of our body fluid through evaporation if our skin's burned off. So that's why like you calculate how much skin basically they lose to total body surface area, and we have to replete it with like IV fluids. And then the important thing is like see how his whole face was burned. So like basically he was engulfed in a huge flame, and you can get burning of your airway and your nasal passageways inside. So you don't see it with your eyes on the outside, but you know like inside it's gonna start to swell very soon. And then they can like, that's the worst thing is like if we just stop breathing. So you have to like immediately here in the ER, you have to support them through that part. Is just get that breathing tube in to secure their airway first. And then later on in the ICU, burn specialists, plastic specialists, they will be managing like how to like deal with this, like basically it's like horrible. I haven't done a burn ICU rotation, but our plastic surgery colleagues have, and the skin gets like terribly like scarred. They have to end up getting like sometimes fasciotomies because it like gets too tight and there's like too much pressure inside, and like they got like multiple grafts and all the things. It's like a really horrible road, and I've taken care of like some really horrible burn patients. I've seen them like luckily for modern medicine they can like survive this, and like, but it's just horrible. And I told you about the patient that I had that like got electrocuted from what is it, climbing a telephone pole?
Right.
Whole body just all burned up, and that smell, you smell that flesh and the burned hair smell. It's just like if you're in the room there, that's like there's a smell of like burned human hair and all that stuff.
Skateboarding, really?
I'm fine, by the way.
You know this guy?
Unfortunately.
You didn't want to be in this shithole. I told him to take me to Presby.
Hospital, so here we are. Hey, what's the golden rule?
No hospitals.
Okay, let's add no skating without a helmet ever again. You hear me?
Yes, Mom.
Wait, is the no hospitals golden rule? What?
Maybe she just want her kid in a hospital in general.
Ma'am, can you close your eyes for me?
I mean, no one wants their kid in the hospital, but
Robbie,
seems kind of an odd rule though.
I will say the don't skateboard without a helmet. Like ER people were like crazy about helmets because I've seen people die from just skateboarding without a helmet. We see too much. I feel like I'm too paranoid about things like accidents.
Jane Doe, looks like she's in her 20s. Obvious aphasia, right-sided hemiparesis, and facial droop.
Who gets a stroke in their 20s? TNK is still the best clot busting possibility.
Shouldn't we do endovascular therapy?
Wait, do they have a downtime on her? Do they have a last known well time?
Dr. King, meet Dr. Matha, one of our esteemed stroke neurologists.
Wait, how? Wait, what? They don't have a last well known time. How do they? How can they push thrombolytics on
is
her?
best suited to work with an MRI machine?
A trained technician.
Someone with a magnetic personality.
Okay, so James is getting really worked up. Okay, why don't you speak up for the audience here?
Oh, you can't push thrombolytics or do endovascular unless it's within the window for stroke. In this case, they don't know when she was last down for. Based on the history, it sounds like someone random called from another country, brought her in, so there could have been many hours. So you can't just push TPA or intravascular just willy-nilly without that kind of information. So I don't think we would generally do it.
Okay, in like regular person talk, let me translate what he just said, which is basically when you have a stroke, and we're talking about the kind of stroke where there's like a circulation, like a clot that caused like a stoppage of the circulation. Right? We're not talking about bleeding strokes, we're talking about the stoppage of the blood flow. In those types of strokes, there are certain treatments that we can offer. One is we can give you a medication, we push it through the vein in the IV and it can bust the clot. It's like TPA or TNK. And the other type of offered treatment is you can have like a procedural specialist, like they're like neurointerventionalists, and they can like go in through your vessels and the veins and go up into the brain and actually like retrieve the clot out. So that's what he's talking about. And the thing is, like with strokes, it's very specific. Like you have to be a candidate because the research has shown like it's most effective in these certain types of patients. And so in order for you to even qualify for these types of treatments, there's many rules. Some of which is the number one, very one that he's talking about is we have to know when these symptoms started, like how long this stroke has been going on for. So one of the first questions we always want to know when someone comes to the ER with stroke is when was the quote last known well time. That's what we always say. What's the last known well time? Meaning like when was the last time they were normal without symptoms? And if you wait at home for 24 hours with your stroke-like symptoms and then come in, we cannot offer anything. That's like way out of the window. It's like generally around like 4.5 hours or something like that. Like it's changing generally. Usually with more research, they'll change the window, but it's a few hours. It's only a few hours. And if you are like a day out, you're out of luck. If you have a known no well time like this lady where no one was with her, they just found her, who knows how long she was like that for, that also counts as a no, like an unknown well time, and you would disqualify for these treatments because we don't know. The risks of giving something like a treatment would be way worse than like, you know, like you don't want to subject a patient to complications if you can avoid it. And for all you know, like she could have been like this for 12 hours, 24 hours or whatever. And the same thing happens for like when patients like they wake up in the morning with their symptoms. The problem is like when was their last known well time? Well, it could have happened 1 hour before they woke up, or it could have happened like 8 hours ago when they went to bed. So when people wake up in the morning with their symptoms and they don't know, like they're like, well, I went to bed normal, then actually their last known well time was their bedtime. And usually a lot of the times that kind of disqualifies you because it's like way over the recommended window. So anyway, last known well time is very important for stroke. So the moral of the story is if you think you might be having a stroke-like symptoms, please do not wait it out. Please come to the emergency room immediately because it's very time sensitive. And if you come to the ER too late, then there's much less things that we can do.
8 hours of sleep sounds really good. I don't know when that happens. That's not possible. It's a fantasy.
What is that?
Oh, she keeps thinking.
Ativan?
Yeah, she keeps thinking that someone's sneaking.
But she has it in her pocket. That's sketchy.
That's sketchy. I mean, it looks sketchy, but I don't think she's taking
No,
it.
she's not taking it.
She's investigating.
Running the ER is a Sisyphean task.
Sisyphus pissed off the gods, so they punished him by making him push this massive boulder up a hill for eternity.
One must imagine Sisyphus happy. You're doing great.
They want a statement from Dave.
She's in CT. Let's clear her medically, and then she can decide when she wants to talk to them.
Everyone's on the lookout for the psychiatrist.
Thanks a lot.
I mean, I think it's a felony, right, to assault a healthcare worker.
Oh yeah, I mean, it's to assault anybody, not just.
No, I don't think it's a felony to just assault a random person on the street. I don't think it's a felony.
Oh really?
Yeah.
Oh, that's true. It's a good question. I don't know.
I think it is.
I don't know.
Remember, he yelled at her last episode, and then he got in trouble for yelling at her.
Yeah.
Oh my
Whoa,
gosh.
what the heck?
Pencil in the ear.
Oh god. I think you're allowed to take the pencil out of the ear though.
What's the status? Diffusion flare mismatch means she's less than 4 hours into it.
Getting TNK now.
Sounds great. Would you mind hanging down here for a bit? I can use your expertise on this.
Can't believe you have the nerve to ask.
Good one.
This neurologist is very jokey. Okay, so he's saying like from the MRI, he can tell like how long the stroke has been going on for. I've never heard that before.
I haven't either, but I believe it. There probably is a way you can do it.
I mean, if the stroke specialist neurologist told me to do it, then sure.
I know the diffusion weighted imaging, they get like, they can time it to the hours for like very acute versus more subacute, but I didn't know they could decide TNK on that. But I'm not a neurologist.
I think the problem is though that like getting that test done, the MRI, will take hours to get that and the results. So unless you're in a place where luckily you have the MRI machine wide open and the radiologist is ready to read it like really quickly, it's like the matter of like getting that test to see how long it'll be. It will just also eliminate a lot of people.
Yeah.
Yeah. So we don't make a lot of decisions based off of MRI results. We just do it off of CT results, which are a lot faster.
What does he have that I don't have? I mean, sure, he's younger. And that hair.
He's talking about the nurse, Mateo.
Yeah.
Mateo. Is she having sex with him?
I don't think his sedation is enough. Like, if you're awake enough to be, like, saying funny things, usually they're awake enough to feel the pain. So basically, we get lots of broken bones. And by the way, this is also a common question I get almost every single time. A fracture is the same thing as a broken bone. But for some reason, we're like, you have a fracture. And they're like, patients always ask, but is it broken? And it's like, it's the same thing. I know to lay people, it seems, I think what they're trying to say is just displaced or not. But anyway, the point is, we do sedation for people that need immediate reduction. And there's only, not every fracture needs to have this done in the ER, by the way. It's only because he had a very unstable fracture, and to put it back in place and to splint it would be super painful. Giving him propofol, like he's either, like he's got to be out enough that he won't feel the pain, but enough that he can breathe on his own. He's going to feel pain and be able to talk, like, ow, my gosh. But yeah, usually the saying funny things when you're coming out of sedation does happen, but usually by that time we're done. Like they're coming out of the sedated state. And yes, people do say really funny things. So they're very uninhibited and say a lot of things that like definitely those are the lighter moments at work, I will say. Yeah. And some people can have bad reactions too. So people can like really freak out too.
Okay then.
Baseball's a fun activity. You any good?
Annie's a southpaw.
What's that?
Lefty.
That's a future Cy Young.
I didn't know what that is either.
Mr. Marty is a
There seems to be a collection of blood behind the eyeball. That pressure's too high. We have to act quickly.
Okay, we'll check the pressure.
We're going to right now.
I mean, there are eye emergencies for sure, and that's one of the things that we learn in ER is we learn a lot of eyeball stuff actually. So that we can be able to speak to an ophthalmologist and know when to refer someone to a specialist. But I don't know that he would cut the line just having like a terrible injury to the eye and like cutting the line like that.
I think this is like, the makeup doesn't do it justice. I'll bet you it was like.
It's supposed to be a very severe eye.
It's supposed to be a very severe eye injury. They just made it look like a really bad black eye, but they can only do so much makeup or something like that. Unless they want to.
Anyway, I mean, I'm not saying that he shouldn't go to the ER, and I'm not saying that he shouldn't be seen in a timely manner, but I just don't know that I would have him like literally jump ahead of the line and be like rush him back. Those are the people that like are not breathing, are actively seizing, I don't know. Okay, whatever. I'm getting into the details of triage, so sorry about that. I can't help it.
An intern has a problem around here. They come to the senior resident, not the attending.
Shady.
He's my attending, and I wanted his input on a patient.
Come to me. First, next time.
Why he yelled at her last time? Why would she go to him first?
Yeah, I know.
I wouldn't.
Pretty bad.
Okay, I will take that slit lamp and you can calibrate for telemetry.
They're holding CT for him.
Let's take a look. Negative side out.
Yeah, that's fancy. There's like a smartphone camera.
Yeah, I haven't seen like a. Yeah, you're right. I've only
Those
seen
are
the really
very
old school
fancy.
ones.
Yeah. I just use a straight up light on the wall.
Yes.
Oh, it was a high intraocular pressure.
Said no bilateral canthotomy trace, excuse me.
What? Whoa.
Okay.
We need to do a little minor surgery to relieve the pressure behind your eye, so we're gonna cut a small opening on the side of your eye, not in your eye. Got it?
Have you ever done one of these?
Okay, so yeah, I have, but like in residency with like people to help me. And then I think I've had to like supervise since becoming an attending. And every single time, this is a very rare procedure. And also it's like, he's like jumping and he's like, we must do this immediately. It's like, no, there is a little bit of time. Like usually I can call an ophthalmologist. I have time to like review the procedure with whoever's gonna do it. But he's gonna jump on it. This is a gory one, so yeah. I don't know, maybe they're gonna show it, you think?
I don't know. We'll see.
Schneider's having trouble pumping air into Teddy's lungs. Burnt skin loses elasticity, now his chest wall's too tight.
What can you do?
We're gonna have to cut the burnt skin, release pressure on the chest wall, help Teddy breathe.
To do a fasciotomy.
This will give us our best shot at preserving his
That's also super rare. I've never done that.
They're not gonna show it.
Feeling for the inferior. How can you see with all that blood?
You can, it's all tactile. Feels like 2 guitar strings.
That's all very true. We all say that stuff. It's like super bloody, so it's like you go by like feel and like you know where the anatomy is and you feel the tendon part that you're supposed to cut and you're supposed to be able to like tell by feeling what you're doing.
Nice, good.
But no, like seriously, like we as in a career, maybe once or twice you will get to do this. It's like super rare. Maybe never, you know.
Sure, 18? Fix. CT can take him as soon as we dress the wound.
Let's page ophthalmology, tell him to prep for surgery.
Okay, so that's the thing. He's like, do it and then page ophthalmology. Like,
yeah,
I mean,
that would never happen.
I mean, yeah, you could do that, but like generally, like if I have an ophthalmologist nearby, I'll call them first before I actually go and do this procedure.
Right.
But anyway, I guess to explain it, behind our eyeball we have like space and we have a normal pressure that our eyeball has. And if you get hit or some kind of trauma, broken bones or whatever, you can get bleeding behind the eyeball, not in the eyeball, but behind. And that bleeding can cause a hematoma and can push forward the eye and cause a lot of pressure added to the eyeball. And that pressure like decreases the circulation to the eye and you could lose vision if it stays like that for a while. It's not like a matter of minutes though, is what I'm saying. It's like you have some time. So in general in the ER, it's like there's only like a few couple things that you really have only a couple seconds, but these types of things, yes, they're emergent, but you have time to like, I found this problem, let's get into CT scan, let's call an ophthalmologist, and then sure, let's set up to do the procedure, but it's not like, anyway. So they have to cut the tendons and all these things to release the pressure that is behind the eyeball so that you don't lose vision in your eye. That's a summary of what was going on.
Burn victim's taken, we need you. Oh my God, I can't wait for this shift to be over.
This is the worst shift ever.
This procedure is called an escharotomy. We need to cut the skin so that the chest wall can expand.
Like, you know who would be more likely to do this procedure at this hospital? What's that trauma surgeon's name? Not Santos.
The female trauma surgeon?
Anyway, she's the one that we would call down to do it.
Yeah.
Like in real life, like we wouldn't be doing this in the ER ourselves. Our trauma surgeon and stuff like that to do this.
Yeah.
Because I've never done this. I forgot it's called an escharotomy since it's cutting through the eschar, I guess.
Yeah, I mean, to be fair, on the show it looks like it's fascia.
This is all new to me. I've never seen this.
Yeah, I don't think I've ever seen it in the ER.
And I've never seen other people do it. Yeah. I mean, it's very cool and something in theory.
Also, don't think eschars form that quickly.
Yeah, eschar, like, it's basically like a scab in a way. Like, that would take at least several hours to happen. Whoa, that's nuts.
That's a lot.
You just like opened up like that. Wow, that's wild.
I would have to see a video, but I don't think an escharotomy would look like that. Essentially, you just want to get rid of all the thick, kind of like basically the non-stretchy skin.
Yeah, they're just cutting through like the tightens like a scabby like eschar, right?
Right.
But I guess it should expand like that. But that's wild. I've never seen that.
Yeah, I've never seen that before either.
Mind if I give her the good news?
No, go for it. And anything else she needs.
I got it.
I would really love to have those work iPads with the results on it where I could walk around.
Yeah.
It's like, this is a very fancy ER, let me tell you. Very high tech.
But I don't think she's a team player.
How so?
She's cherry picking cases. You've always said that being in the pit is like playing a team sport.
He's saying cherry picking cases, that means like, it basically means like we should like all like be a team, right? All seeing all types of patients no matter what they are. But if you cherry pick, you're like, I don't want this patient. I only want this one. I don't want this one. I only want that one. That's not like really being a team player. That's what cherry picking is.
You're clear to go back to work if you want. Or home.
Not ready yet. Yeah.
They've both had a traumatic day. She had her miscarriage.
And she got punched.
Yeah. They said it's like effed up day, yeah.
Yep.
She's waking up.
They gave her thrombolytics, right?
Mm-hmm. Yeah.
Are you trying to say okay?
Yes, the thrombolytics are working.
That's good. Like in that case, like the thrombolytic actually made like a noticeable improvement to her. That's like a good feeling in the ER when you can actually make something that good happen like that.
Yeah.
And that it's rare. We'll go days without like good things like that happening.
I was getting ready to take her up when she developed angioedema and her stats dropped.
A little bit of stridor, swollen lips, swollen tongue. Here, this is a side effect of the medication we gave you.
Oh shit. Okay,
That's clearly.
This is for sure like a true emergency. This I would jump on like
Just
immediately.
angioedema. I can reverse this
That's
swelling
I
fast
don't.
with
I don't know. Have you ever seen a tongue that big from angioedema?
Yes.
You have?
I've seen a tongue so big that the jaw dislocated.
No way.
Yeah.
Wow.
But that was not actually angioedema. That was like actually like someone that had a bleeding, like was very, I think was an alcoholic, so very like.
He bit his lips and.
Yeah,
started
accidentally
bleeding.
bit his tongue and like just was prone to bleeding.
I see.
But like tongues can get huge,
Wow.
and like it's scary. You can stop breathing.
I think
so-
I've seen one that big before.
Yeah. In that particular case, we did a nasal. I didn't do it myself, but I watched them do a nasal intubation.
Are we intubating? Are we not intubating?
Not.
That would not be an easy intubation, let me tell you. Like, how are you gonna get a breathing tube into here? Like, it'd be so difficult.
Would you intubate that? I think you probably would.
Dr. Mettler will want her intubated for the thrombectomy?
Not necessarily. If she can talk and move during the procedure, then they can monitor any changes in the neural exam.
Yeah, like, I mean, no, I don't think for sure yes, because like, even though it looks terrible here, if she's still able to like breathe and like interact, like you just closely watch them. And like, as soon as there's any signs, then yes. I don't know, it's tricky. Like this one would be tricky. But like, we don't intubate all angioedema patients. Let's just put it
Yeah, of
this
course,
way.
of course. Yeah, no.
So, I mean, people come in with huge tongues and they don't always get intubated.
Oh, interesting.
Yeah. But I mean, it's scary.
Yeah.
That is the kind of stuff that when I see that as a doctor makes me want to change my pants afterwards, because I'm like, I shit my pants because I was so scared.
His breathing with the ventilator, and we'll keep his wounds clean, look for any signs of infection.
Then later, the plastic surgeons can do skin grafts.
Teddy's condition is very critical.
I think the problem with these patients also is like, we don't know if they're going to be okay. I mean, yes, his breathing's okay, but they have complications and they get infections.
Yeah, exactly.
That's like a big risk, is like they get lots of infections too.
Yeah. That's why they have to go to the burn unit. Just keep it completely sterile.
Yeah.
Keep it super high humidity. I've never walked through the burn unit, but I heard it's just like a sauna in there.
Oh.
Because you have to keep it high.
Well, yeah. A burn unit has to be warm because they basically like don't have any skin to keep themselves warm. Yeah.
Yeah.
His chance of dying in the next week is over 90%, but he's a lot more likely to die of sepsis before his kid is born.
Yeah. So he knows the same thing. Like they have a lot of complications afterwards.
So he has the surgery, stays overnight, he goes home tomorrow?
It depends on how the surgery goes and what his post-op results are like. It could be as soon as tomorrow, yeah.
I just don't know how like these doctors answer like how long are they be in surgery and all. Like you ask me these surgical questions, I'm like, I don't know. I only work in the ER. I just work here, man. I don't know.
Yeah.
You know, like when are they gonna go home after they get admitted? I have no clue. It's just when they get better, you know. You ask me questions about the surgery, we should maybe ask the surgeon. I don't know.
And, you know, a new foot massage place just opened in the Strip District. Do you want to go on Sunday?
For sure.
Okay, cool. I'm free Sunday.
Oh my God. I mean, Harrison would love a sitter closer to his own age.
Well, sure.
Dr. Santos?
Well, when they do, just send them to me. can make it look like an accident.
This lady's funny.
That lady's funny.
I heard there's been some inconsistencies with meds intended for your patients. Have you ever taken a patient's medication? Is the imprint code on these pills going to match Louis' Librium?
What's the Librium that they were supposed to give the alcoholic?
Go home, Frank.
No, I'm not high. You've seen what I do.
Still
Rob.
can't steal
Could a drug
pills,
addict do
bro.
what I do?
Yes, a drug addict can do what you do.
Mm-hmm.
You are done.
That's got to be the end, yeah. It can't get any worse than that.
Yeah.
Okay,
It's
so
pretty
did you
bad.
suspect him?
Yeah, I mean, they've been setting
yeah,
up
they kind
for...
of been setting it up, right?
Yeah, they've
I
been
don't want to
setting
say
up-
anything, but yeah.
Yeah. I mean, I think you know more about this kind of stuff than I do.
Substance abuse addictions in doctors, though.
Oh, I mean, we see a lot of it.
Yeah. High functioning, very smart, very high achieving, educated, physicians definitely have. I don't know if like physicians also have like higher rates of substance abuse than like other types of professions too.
I mean, anesthesiologists certainly, dentists
Yeah.
certainly, because they have anyone who has access to
Who
it
has
like,
access to
super
it.
duper easily.
Yeah.
Is yeah.
Yeah, so that's something we were always told, like anesthesiologists like have a high rate of it. They're around like, substances and benzos and things like that. But emergency medicine is also same thing. We're around these controlled substances, sedative meds, benzodiazepines, like opioids as well. I know someone that has battled with addiction, and so it does happen to people, but it just made me sad. It's important to confront it, and it is important that like he can't be working like that. It's not okay to steal, obviously. You can lose your medical license for sure, but I just felt so bad that he wasn't like so like empathetic towards him in a way.
Yeah.
He was angry. He was really angry. Like, I know it's a disease, and I wouldn't want to obviously we'd have to confront them. They can't work. They need help. But I don't know if I would just be like, get out,
No, and that would never happen that way. Regardless of the situation, it would never happen that way. You have to talk to like a million people before you. I mean, you'd be sent home that day, but you would have to. I mean, the main thing is, frankly, he seemed like he was fine. I do believe that he was like he was functioning, but the main thing is he can't steal from patients. That's like you're endangering people at that point.
Well, he's stealing from patients, but stealing in general, stealing from the hospital. Even if it's not stealing from the patient, he's stealing from the hospital. But yeah, like it's true. Like addicts can function while taking their substances. They just like kind of basically need it to be normal. So they don't necessarily will feel a high with the doses that we would take because their body has a tolerance and it's built to it and is dependent on it. And I really do believe that addiction is a disease and something that people battle like daily, and it's a chronic thing. You don't just get over it one time and you're not an addict for the rest of your life. Like, no, I think it's a real disease, and we see it, and it's sad that that one of the doctors, it happened to them. That makes me really sad.
Yeah, I agree.
But there is hope. I would say, like, if you know someone that is dealing with addiction, or you yourself is, like, please get help, because this might have happened today, but that doesn't to say that doctor, this character in this story, can't go on to have a career. He just maybe shouldn't be working around substances, you know?
Yeah, it's very much genetic. Ozempic apparently just treats it, so.
Oh, that's the latest news, like treating addiction, right?
Yeah.
Yeah. Up to date with the latest news here. Nerd. I'm like, I don't know. That was that scene really like, it was, and Robbie was sad. Robbie was like crying. Like, I think I'd be heartbroken too.
Yeah, he did it out of sadness and anger. But yeah, in real life, you would have to be, it probably wouldn't go down quite like that.
Yeah, but that kind of stuff does happen. I will say less now because they try to make things, two people witness things getting taken out and putting back, and so they try to limit it. But so I think back in the day it used to happen more than now, but there's people find ways. So overall thoughts of the show so far?
Sounds like it should win an Emmy.
Oh yeah, right. So we're filming this after the Emmys happened, and the Pitt just won for best drama series. And I was so thrilled. I gotta say, I felt like a personal win because, we're pretty much part of the show now. Noah Wiley, he won the Emmy for the best actor in a dramatic series. I was like, so you mean he won an Emmy for playing an emergency medicine doctor? So for playing me in real life. So basically that's my Emmy. But I will say, like, when people ask me, like, do people ask you if you like The Pitt? Like, do we talk about, like, have you seen The Pitt? Do you like it? Like, what do you say when people ask you?
I don't think anyone's asked me so far.
Oh, really? People ask me all the time at work.
Really?
I mean, because
because
I'm ER, right? They'll be like, oh, have you seen The Pitt? Like, what do you think of it? And I will say, honestly, it is a good show, but I don't know if I would say I like it.
Really? I thought it was pretty good.
It's not because I don't like it. It's because it just feels like work. Does that make sense? It's not that I don't like it. It's just, it's so hard for me to watch it.
So draining, yeah.
It's draining. And that's why it takes us so long to get through these things, because like we'll watch it and then we won't watch for like 3 or 4 weeks because we're like, I'm so tired from all this work that I've already done. And like watching this is like, it's not relaxing to me. Let's put it this way.
Yeah, it's definitely not a relaxing show. It's very good though.
No, I'm saying it's a good show. I don't know if it's my cup of tea. I definitely wouldn't watch it if it wasn't to explaining it to people, like what's going on.
I would also recommend there's a podcast. It's a podcast episode about the show, about how there was all this drama with Michael Crichton, and it goes all the way back to the days of ER.
Oh, it's talking about the Pitt and the creators of the Pitt and ER and all that stuff.
Right, nothing to do with medicine, just about the show. It's very interesting. Apparently, like the Crichton estate is sued.
Yeah, look it up. You can look it up. Tell us what it is. Good show. Pretty accurate. Not every single day is crammed in like this. This is like a career's worth of like bad days and stuff, and really rare cases. Kind of stressful for me to watch. I get like, it just feels too much like real life, which is their point, right? So just not something I would recommend as light watching for me. I think like as an outsider though, people can watch it if you aren't like working in ERs, because it's like interesting. Yeah, and it's
interesting, it's dramatic. I mean,
interesting and dramatic.
Makings of a good show. But yeah, for us, or for you, more so.
Yeah, no, it's like, my decompression of choice is as far away from the emergency room as possible. I prefer trashy reality TV. But I mean, basically anything like far away from what I do at work.
Is my favorite new TV show of this year a ripoff. The podcast is called Search Engine, and it's the September 26th, 2025 episode.
All right, well, thanks for watching, and we'll be back with episode 11. Thanks.
One day.